focus on vaccines today, but the first couple of slides will just talk about coronavirus in general and also how it affects children. And that'll help us set the stage to think about vaccines towards the end of this talk and to open up for questions. Some of the figures and graphs are a little dense, and that's okay if you don't fully understand all of it. I just want you guys to see where I'm drawing my information from and to know that everything we're talking to you about comes directly from scientific literature. Dr. Patty, am I going slow enough? Okay. So I just want to start first with coronavirus. And it's important to know that there are many types of coronavirus, and that coronavirus is actually one of the most common causes of cold in humans. There are 4 main types of coronavirus which cause colds in humans, and they tend to be fairly mild. They might give you a sore throat, runny nose, congestion, and cough. And the name coronavirus actually comes from the way it looks underneath the microscope. If you have a really powerful microscope called an electron microscope, the coronavirus has these little spike proteins around it, and those spikes look like a crown, hence the name coronavirus. Now, coronavirus also affects other animals, and bats in particular have lots of different types of coronavirus. When coronavirus goes from a bat to another animal, that's called an intermediary, and then it can go from that animal to a human. And that's where major outbreaks come from. Two recent major outbreaks have occurred in the last 10 to 20 years. The first was the first SARS coronavirus. This occurred mostly in Asia, and it was characterized by really severe disease. A fifth of those patients ended up on the ventilator, and 10% of them died. Now, what was striking about that SARS virus, and this one as well, is that it doesn't tend to affect children. In fact, no infants or children died with that SARS outbreak. The other interesting part is that SARS, the original SARS coronavirus, came from bats. It went to these cute animals called civet cats, which sort of look like a really sleek bobcat, and then went from there to humans. The other recent outbreak was MERS. MERS went from a bat to a dromedary camel, and from dromedary camels to humans. Now, MERS was actually much worse in terms of causing severe disease than SARS or COVID-19. Fully a third of patients died. And thankfully, that outbreak extinguished pretty quickly. So only 1,700 people were infected and 678 deaths occurred. This current pandemic is caused by SARS-CoV-2. So it's very similar in its structure to the original SARS virus. And SARS-CoV-2 causes COVID-19, which is the infection that is characterized by lung disease and viral pneumonia. Now, this SARS virus probably came from a pangolin, which are these really cute animals that sort of look like an armadillo. They are indigenous in Asia, and they're hunted for their scales. And we think the original outbreak occurred in Wuhan because of the seafood and live exotic animal markets. Now, you all know fully well how severe this infection is. It's highly transmissible, and it causes severe disease in adults. But it's striking how it seems to not affect children quite as much. There are a couple of large reports that came from the CDC. The first was published in spring of last year. And what the CDC showed was that there were not that many infections occurring in children. And in fact, the hospitalized children tended to have underlying medical conditions, almost 80% of them. The second large CDC paper came out a few months later, and it showed that, again, the cumulative incidence was low in children. And you can see that here in this sort of complicated chart. If you look at the red arrow, this is age group 0 to 9 and age group 10 to 19. And this is the number per 100,000 people. So 51 per 100,000 and 120 per 100,000 versus 400 per 100,000 in the general population and 900 per 100,000 in people over 80. Perhaps even more importantly is not only were children less likely to get infected, when they were, they had less severe disease. So the red arrows show the incidence of hospitalization amongst children, the rate of ICU admission, which was only 0.7%, and the rate of mortality, which was actually less than 0.1% and got rounded in this chart. The actual number was 0.06%. As compared to adults in the overall population, which was 14, 2.3, and 5.4 respectively. So in all three accounts, children had much less severe disease. Not only that, when children do get infected, they seem to transmit it less often as well. In order to understand transmission, we look at these studies called contact investigations. This is a very well done contact investigation study done in Taiwan by scientists there. They looked at 100 adults who had confirmed COVID-19 and 2,761 of their close contacts, mostly people who lived at home with them. And the most important part of this for our purposes is this red arrow right here. In all of those 2,700 close contacts, there was only one child who was a secondary case, meaning that there's only one of them out of these 2,700 people who actually contracted an infection from one of the 100 adults who had confirmed COVID-19. Even when you look at super spreader events, it does seem that children tend to be less affected. This is a really important study that was published last year describing a Britishman who went from Singapore, got infected, and went on vacation in the French Alps in a chalet. And when he went on vacation, he infected 75% of the other occupants. One of those occupants was a child who was school-aged. And then that child went home to France and went to 3 different schools while he was still symptomatic, meaning that he had cough and runny nose. And in the course of visiting those 3 schools, exposed 85 contacts. So 85 other people were around him while he was still having a cough and runny nose from COVID. Of those 85 contacts, none of them developed symptoms, and 55 were tested and were found to be negative. In the US, there have been multiple studies looking at children and transmission as well. This is the most recent large study looking at transmission in schools. It was published in a journal called Pediatrics. It described 11 school districts in North Carolina that remained open with 77,000 in-person students. During the study period, there were 773 documented cases, but only 32 cases of secondary transmission, meaning of those 773 documented cases, only 32 only 32 of those infections were from spread in school. Even more striking, there were no cases documented of a child infecting adult, and the adults in this study were teachers and other staff. They also showed that most of the secondary transmission, so infected people giving it to another infected person in school, related to absent face covering, so people who weren't wearing masks. And most of that was in special education, which is understandable. The other really important thing they showed in the study was that the transmission in schools mirrored the transmission in the community. So if there was a lot of COVID in that neighborhood, there was a similar amount of COVID in the school that served that neighborhood. And it also highlighted that most of the people getting infected in these schools were actually getting infected out of school, so probably at home. And we actually know that a child's biggest risk of getting infected.
Dr. Ramchandar, would you repeat that section again?
Do you want me to do the whole slide again?
Just the sentence before what you just said.
Yep. So neighborhoods with high transmission have similarly higher transmission in school. So the transmission in school mirrors I should say that differently. The incidence in schools mirrors the incidence in the community that the school serves. And it also highlights that infected children tend to get the infection from outside of school, not in school. And we know from other studies that most children who are infected get it actually from their parent. So to summarize all of that to this point, children are less likely to get coronavirus, so COVID-19. When they do get it, they are less likely to be hospitalized, go to the ICU, or die. Also, when they do get infection, they are less likely to give it to other children or adults. Now, there is one thing that we should talk about, which is this multi-system inflammatory syndrome in children, MIS-C. This is a new syndrome that's only been described during this pandemic. It's a post-infectious inflammatory syndrome. So when you get infected, 2 to 6 weeks later, the body has this inflammatory response, even though the virus is actually gone. And we call that autoimmune or autoinflammatory disease. And so the treatment for MIS-C isn't antivirals. You're not trying to get rid of the virus anymore. You're actually trying to calm the inflammatory system, the immune system and inflammation down. The other thing we should mention as well is that this is not Kawasaki disease. When we first started seeing these children, there was some concern that this was Kawasaki disease, but we know now that these are two separate entities altogether. There are a couple of large studies that have looked at this, but this is one of the largest. It was a study that was funded by the CDC, and it's called Overcoming COVID-19. The scientists that ran the study looked at 38 children in hospital all over the country and identified 186 children with MIS-C. They found that most of these children were school-aged, about 8 to 10 years of age. Fully half of them ended up in the ICU, so it was quite a severe illness. But thankfully, the mortality was really low. The other important thing is that MIS-C, so the incidence, the likelihood that it's going to happen, depends on how much COVID-19 you have in that area. So the places that saw a lot of MISC were the places that had seen a lot of COVID-19. And they also found that there was a delay. So when COVID-19 peaked, 2 to 6 weeks later, MISC would peak. And you can see that in this bottom chart here, where this yellow line is the peak of COVID-19. And then a few weeks later, these little bars that are red are the MISC cases occurring. So we kind of already summarized to say that children can get coronavirus, but when they do, they're often less sick and they're less likely to transmit it. That's not to say that there isn't some risk. Children with active infection can still end up in the hospital. And there is this MISC, which can occur in somewhere around 2 to 100,000 children, 2 to 4 weeks later. And that leads us to consider this decision of whether or not to vaccinate, both ourselves and our children. So we start from this first point, that there is still a risk to children and then also to the people around them. And in any unvaccinated population, there's an opportunity for the virus to continue proliferating. It keeps replicating and spreading from person to person. Now, we're going to talk more about mutations later, but this is really important when we talk about vaccines, because as vaccines proliferate and replicate, they make mistakes. And those mistakes usually lead to nothing. But every once in a while, those mistakes can allow the virus to either transmit more effectively or be more damaging to the person that it infects. And those are the variants that we've been talking about and hearing on the news. So the more the virus is allowed to replicate in a population, the more likely you are to have variants. And the more variants you have, the less likely the vaccines are to be effective. And that means that you're in a race against time. You want to try and vaccinate as many people as possible to reduce the likelihood that you have these escape variants that might not be as effectively prevented by vaccine. There are currently 3 main types of vaccines out there. mRNA vaccines are the Pfizer and Moderna vaccines. This is where you take a sequence of RNA, which is, we all have DNA. DNA gets turned into RNA, and cells read RNA in order to make proteins. So if you take an mRNA sequence that correlates with protein from coronavirus and give that to a human cell, the human cell will make those proteins and release them. Then the immune system sees those proteins and develops immunity. Now, the really elegant thing about mRNA vaccines is that mRNA is sort of like the burn notice from a CIA movie. As soon as it goes into the cell, there's an expiration date and it goes away. So it's not like if you give an mRNA vaccine to someone, they're going to make the protein forever. The mRNA will degrade and go away. The other thing you should know is that mRNA does not affect human DNA. This is mRNA from the virus. It never goes into the nucleus of the cell. It never affects the human genetic material. The other main type of vaccine is a viral vector vaccine. This is where you take a virus that already affects human cells, you neuter it so that it can't cause disease, and then you put proteins from the coronavirus into this degraded virus and inject that into the human body. The immune system from whoever you gave it to sees that virus and attacks it. In the process of attacking that virus, it will also see the protein from coronavirus. And so you'll get immunity to the coronavirus as well. It's like a Trojan horse. The third type is a subunit vaccine. And this is where you take the proteins from coronavirus, you put them in a molecule, and you inject that into the human body. The immune system sees those proteins and generates an immune response and memory to those proteins. Now, there are a number of available vaccines that, that we don't have to get into too much detail in. mRNA 1273 is the Moderna vaccine. This is an mRNA vaccine that we just talked about. BNT162b2 is the Pfizer vaccine. And AD26 CoV-2 is the Johnson & Johnson vaccine, and that's the viral vector. And those are the three main vaccines that are available in the US right now. So I think we've set the stage at this point. And we want to address these 5 questions that were received from you ahead of time. When can children get the vaccine? Do I still need to get tested if I'm vaccinated? Can I still have the virus even if I'm vaccinated? Does the vaccine work against the newer COVID variants? And if I get infected with COVID previously, should I still get a vaccine? So we'll address each of these questions. First, when can children get vaccinated? Now, there is one vaccine that is licensed by the FDA, excuse me, down to 16 years of age, and that's the Pfizer mRNA vaccine. The other vaccines have not received EUA approval yet, and that's because you need a large trial called a phase 3 trial, which includes thousands of patients, to show both efficacy, meaning that it works to prevent virus, and safety, so knowing that there aren't major side effects of the vaccine, before the FDA will authorize it for use. Then the CDC and a group within the CDC called the ACIP will make recommendations for the vaccine and how to distribute it to the population. And we're still waiting for that for most of the major vaccines. There are currently multiple ongoing pediatric trials. But especially for younger children, school-aged and infants, it may be a matter of months before we see those get EUA approval. The Pfizer vaccine, the company did study it recently down in the 12 to 15-year age group, and the results were really encouraging. In 2,260 adolescents studied, there were only 18 cases. There were 18 cases in the placebo group, meaning that they got not the actual vaccine, versus none in the vaccinated group. So it was highly effective, and it was very safe. And Pfizer is hoping to get EUA approval for adolescents soon. So your next question, do I still need to get tested if I'm vaccinated? This is a great question, and it really just depends. It depends on your degree of exposure and your symptoms. But in general, if your exposure was minimal and you don't have symptoms, you probably don't need to get routinely tested. So I'll give you an example of a low-risk exposure. If you saw someone if you were briefly in contact with someone who may or may not have COVID-19, you're outside, then and you don't have any symptoms, you probably don't need to go get tested. If you were exposed to someone who definitely had it, you spent upwards of 15 minutes in close contact with them, then you probably should get tested. And especially if you do have symptoms, then you should get tested. So it's really all about your exposure. And the other important thing, I guess, to keep in mind is how soon it has been since you've been vaccinated. So really, for the mRNA vaccines, Pfizer and Moderna, you're not fully immunized, technically, until 14 days after your second shot. So your next question, can I still catch the virus even if I'm vaccinated? And the answer is unfortunately yes, you can. It's all about your risk, again, and the intensity of your exposure. So if you're vaccinated and you have this brief exposure, it's very unlikely that you'll get COVID-19. And if you're using risk mitigation strategies, so you're wearing your mask, you're social distancing, and you're fully immunized, in a normal healthy person, your risk from that sort of encounter is less than 1%, very low. To illustrate that point, there's this study that was recently published in a journal called MMWR, which is the CDC's main journal. And they carried out this study called the HEROES trial, which followed healthcare workers, so people who are consistently exposed to COVID-19. And they tested them weekly, regardless of whether or not they had symptoms. And what they found was that healthcare workers that had 2 doses of an mRNA vaccine, Pfizer or Moderna, less than 10% of them contracted the infection after they were vaccinated. So they had a greater than 90% efficacy for getting the virus at all. And as we know from previous trials, the efficacy for preventing symptomatic disease, so meaning that you have the virus and you have symptoms, is upwards of 93 or 94%. It's a very good vaccine. This question, does the vaccine work against the newer variants, is very difficult. And I'll tell you that there isn't actually enough data to answer this question well yet. For the most part, the mRNA vaccines and J&J, the Johnson & Johnson vaccine, probably do have some efficacy against B117, which is the UK variant. There are at least 2 studies demonstrating high vaccine effectiveness with the Pfizer vaccine. And in a study carried out in Israel, they demonstrated greater than 90% efficacy. And during that study period, very likely B1117 was circulating. They just don't know to what extent. So we can't give you the exact number. We can just tell you that there is probably some efficacy against it. All vaccines seem to be preventing hospitalization and death, though how much it does that varies based on the vaccine and the variant. And for some variants, that efficacy is probably a little less. And 2 of the ones we are worried about are B135, which is the South Africa variant, and then P1, which is the Brazilian variant. And the rise of these variants is one of the really important reasons for all of us to try and get vaccinated as soon as possible. Okay, this is the last question. If I got infected with SARS-CoV-2 previously, should I still get the vaccine? The answer is yes. There are a number of studies now that have shown that getting a vaccine after you've been infected is basically like getting a booster dose. So when you have an infection, you develop some immunity, but over time, that immunity will wane and you become at risk again. If you get the vaccine, it boosts your immune response, and so you get a better immune response if you're exposed, and it lasts for longer. Right now, the CDC recommends that infected people wait until their active infection has resolved and their quarantine period is over before they get the vaccine. And you do probably have about 3 months worth of immunity after you're infected. So there's some wiggle room there, especially in places where there's not wide availability of the vaccine. So those were the main questions. We'll stop here and open it up for any questions from the audience, and Dr. Bradley can jump in too to help answer some of those questions.
Thank you, Dr. Ramchandar. So folks, you can either unmute yourself and ask a question, or if you would prefer, you can type your question into the chat and I can read it out loud. So who would like to go first? Does anyone have a question? Okay, so I have a question from Jennifer. So Jennifer says, when do you think the vaccines could receive FDA approval or move from EUA approval? I'm guessing this is for children, Jennifer, or is this in general?
In general, for adults and then children.
So I can take a crack at this and let Dr. Bradley mop up. But to go from EUA approval, you really need multiple phase 3 trials, so at least 2. So to go from EUA to full approval, so having an actual label might take some time, even for the mRNA vaccines. For children, those studies are currently underway. The mRNA vaccines right now are what are in a stage called dose ranging. So they're trying to figure out the right dose for children. Once they figure out the right dose, then they'll go and start actually looking for efficacy data. And that takes time. So it'll probably be a few months before they actually have the data together to start applying for EUA approval. So it could be into the summer before we start to see some of that. And then there are a number of vaccines that are much further behind. So the Moderna, Pfizer, Johnson & Johnson all are working on that actively and recruiting patients. AstraZeneca is trying to get there soon, and some of the other vaccines, especially Novavax, which is a subunit, have not gotten there yet.
Thank you.
All right, so the next question.
I can add just a little bit to that.
We'll go for it.
Dr. Ramchandar did a very nice job. Normally, a company will ask the FDA the minimum number of patients they need to study before they could get approval. And in the law, federal law, you do need to do 2 well-controlled, appropriately statistically powered studies. But during the COVID pandemic, there have already been millions of doses of Pfizer vaccine and Moderna vaccine given. So it's just a matter of how long we have data after the original cohorts were immunized for safety. So I suspect that that by this fall, we'll have a year's worth of safety data and follow-up data from the original group who were immunized in the studies. And we'll probably move from authorization to full approval by that time at the latest.
All right, thank you. We have a question from Susan. Is it safe to travel on a plane with unvaccinated children if parents are vaccinated?
This is a good question that I wrestle with myself and my little kids. The answer is probably, but it depends on a lot of different things. It depends on whether or not your children have any medical issues. If you're visiting people that are vulnerable who are unvaccinated, and the type of travel you're going on. So if it's a short flight and you're visiting healthy people who are vaccinated, it's probably reasonable. But it would depend on every situation, and probably requires a conversation with whoever you're actually visiting. But certainly if you have vaccinated parents and you're visiting vaccinated grandparents, the likelihood that your kids would get infected on a plane and then cause disease in the grandparents is probably pretty low.
Oops, sorry. We have a question from Maria. If the factor chosen to determine which vaccine to get is based on efficacy rate, which vaccine brand should I select?
That's a good question. You know, honestly, at this point, the vaccines that are available, Pfizer, Moderna, Johnson & Johnson, are all very good. And so if you can get the vaccine, the time to get it is now. So I wouldn't wait or shop around, just get what you have available. And overall, if you have an option, it probably just doesn't even matter that much. I would just get what you can as soon as you possibly can, because that's really what makes the difference, is trying to get as many people vaccinated as soon as possible. And they're all very safe.
So just to add to that, efficacy can be measured many different ways. If you want to know if the vaccine prevents death, they're all equally effective. If you want to know which vaccine prevents hospitalization and severe disease, they're all equally effective. The differences that have been published are between those like Pfizer and Moderna, which will even prevent runny nose and some headache and flu-like illness much more effectively than the Johnson & Johnson vaccine, or in the other studies that have been done in England, the AstraZeneca vaccine. But since our goal is to prevent death and hospitalization, all the vaccines are effective in that way.
Okay. We have a question from Rebecca. Is one of the vaccine types better for children? Or I guess, which of the vaccine types is better for children? mRNA versus viral versus subunit?
So subunit probably won't be around for a little while, but mRNA versus viral, the FDA will only approve them for children if they're shown to be very safe. So you won't have to make a decision about which vaccine to get based on safety to your children, because the FDA will do its due diligence to make sure that all of them are very safe. And as far as like better, so efficacy wise, like Dr. Bradley was saying, they will meet the bar to prevent severe illness. And again, it's what you can get when you can get it. And that's the most important thing. You don't have to worry that one is much better than another.
All right, let me scroll up and get this other question. Okay. Have any studies started for the B1617 variant? I know it is new, but it spreads rapidly and is a so-called double mutation of the virus. And this question is from Creed.
So that's a great question. There are a number of variants, and B117, B135, and P1 are the most widely spoken of, but there are actually variants all over. And many of them don't matter that much. So some of these are more transmissible and some of them are a little bit more deadly or cause more severe disease. And variants will always be a problem if virus is still replicating. So the most important thing is to get everyone vaccinated to prevent more variants from coming around. Now, many of these companies are already looking ahead at these new variants, and in their next iteration of vaccine, they're incorporating those mutations. So they are actively looking, as we speak, at all of these variants and trying to design vaccines that are going to take care of them. So I guess the answer is yes. There are companies actively looking at this. All of them are.
Okay, so we have another question, or we have a question from Isabel. Todas las vacunas, Pfizer, Moderna, etc., tienen los mismos components.
All the vaccines have the same components, Moderna, Pfizer, and Like, what was the last one?
That question, I have to admit my Spanish isn't terrific, but they're asking if all of the vaccines have the same components. And the answer is not exactly. They all differ slightly. The different classes of vaccines are more similar. So Pfizer and Moderna have a lot more of the same components. The way that affects you really is if someone has an allergic reaction to one of the components, that might be a reason for you not to get that type of vaccine again. But so far, all of them have very low rates of anaphylaxis. So severe allergic reactions seem to be very low with all of these types of vaccines. The mRNA vaccines, the risk of anaphylaxis is 1 in 100,000.
Okay. So we have, oh, I'll wait for Patty to finish. All right, so we have a question from CC. Can you get the COVID virus after getting the vaccine?
Yeah, so you can get the COVID virus after getting the vaccine. None of the vaccines is 100% effective, which means there is always some risk. That risk depends on your exposure and the amount of immunity that you got personally after the vaccine. In general, if your risk, so your exposure was low, so in passing, maybe you're outside and you walk past someone that had COVID, and you've been fully vaccinated, your risk is very low.
So I guess my question to follow up for this is, so can you still carry the virus after being vaccinated? Can you still carry the virus and not present any symptoms?
You can. The number of asymptomatic people seems to be somewhere between 20 to 40% after they contract the infection. And that's still probably true for people who have been vaccinated. So if you are vaccinated and get the infection, there's still probably somewhere around a 20% chance that you could have the virus and not have symptoms. We do know that if you are asymptomatic, generally the likelihood that you transmit it to other people is lower. And some large studies have shown that that reduced risk is as much as 80%.
Okay. So we have a question from Bob. I know many people are concerned about the risk of blood clots with the Johnson & Johnson vaccine. Could you put the risk in context?
Absolutely.
I've heard that the risk of serious side effects is much higher with many commonly used medications.
So that's a terrific question. And I think it's always good to think about our benchmark of risk tolerance with COVID-19 and other things. And this is just wonderfully put. So with the J&J vaccine, Johnson & Johnson, or Janssen, it's all the same thing. They found that there was this risk of a clotting disorder in some people. And so they put a pause after 6 of these cases had been reported. And after waiting for a few weeks, just to make sure that all the data had trickled in, they had a total of 15 cases that occurred in primarily middle-aged women. Now, some of these cases were severe, but what they found was that it seemed to be associated with this protein that's really important for regulating how your platelets clot in your bloodstream. And the vaccine in some of these women may have led to the development of an antibody. Instead of going towards the vaccine, it went towards this protein and put them at risk for this clotting disease. After collecting all of the data, so these 15 cases, and looking at the other 8 million people who have received the vaccine, they figured that the risk of this clotting disease in middle-aged women, so about 20 to 50 years of age, was 7 per million. So very, very low. I'll give you an example of another vaccine, like the measles vaccine, where the risk of having low platelets, not quite as severe as this clotting disease, is somewhere around 1 in 30,000. Or anaphylaxis, so a severe allergic reaction, which is 1 in 1 million for most vaccines. Even put a different way, the risk of a clotting disease in most people that get the J&J vaccine is less than the risk you take of getting an accident when you get in your car.
Does anyone else have any questions? You can either put it in the chat or if you want, you can unmute yourself and ask a question. Don't be shy. No? Anyone? All right, we'll give it a few more seconds and then we'll close the session. One question I had, and I don't remember if we covered it, but do we have a sense of the time frame for all kids being able to get the vaccine in the next, is it this summer? Is it fall or is it winter?
It's very unlikely that all children will be vaccinated by this summer. We may see some of the first EUAs, the applications come around this summer. And Dr. Bradley might have a better answer for you, but I don't think that we would have wide dissemination of the vaccine probably until fall or late into winter.
That is what the current projections are. The Pfizer vaccine is farthest along in investigating what the right dose is for children. And they hope to have their vaccine trials completed in children in most of the age groups by this fall. Then the FDA reviews all the data and we hope to have approval actually early next year. So that's the point when all the kids will be asked to be immunized. Won't that be nice?
Yes, that will be very nice. Susan has a follow-up question. Regarding flights with unvaccinated kids, would you change your answer for a 4-hour flight? Is it still probably safe?
The answer is probably. It's still probably safe.
All right, folks, do we have any questions? Please don't be shy. This is a great opportunity to, there's no dumb questions. Just lay it out there. Okay, we have a question from Denise. Are the side effects higher with people who have underlying health conditions when it comes to getting the vaccine?
So far, we have not seen a higher rate of side effects in people with underlying health conditions. The only caution that we've been giving people is that if you do have underlying health conditions, the vaccine may not be as effective. So you still would want to maintain all of your mask wearing and social distancing and that sort of stuff in the right context, because you may not reach that 94% efficacy if you have, an underlying issue that affects your immune system, for example. But that's not to say that you shouldn't get the vaccine. It's maybe even more important for you to get it.
Okay. We have a question from Isabel. ¿Las vacunas todavía no están aprobadas por la FDA?
The vaccines are not approved by the FDA.
I have to confess, I can't understand.
She's asking if the vaccines are effective. I mean, approved by FDA. Oh, I can write.
If I may, I can translate that. She's asking if the vaccines are approved by the FDA.
So Pfizer, Moderna, and Johnson & Johnson all received EUA approval by the FDA. They're approved for the general public to get the vaccine.
So just to clarify, we're in a national emergency, and EUA means emergency use authorization. So in non-pandemic times, the FDA will either approve a drug or not. But during a national emergency, there's a middle ground where the FDA believes that the vaccine will be life-saving. And so it will provide an emergency use authorization, which is different than a full approval or licensure. So the vaccine is being distributed and being used with the full knowledge and encouragement by the FDA. But until more data are collected on safety, the full approval, which will continue even after the national emergency goes away, that full approval will allow companies to continue to use the vaccine after the emergency. Does that make sense?
All right. Do we have any other questions?
I have a question.
Yes, go ahead.
So if anybody is interested in their child potentially participating in some of these vaccine trials, is that possible?
That is possible. So UCSD is a Moderna trial site. They are just starting their dose ranging part now, which does not require many children, but the next phase of the trial will start soon. If you are interested in that, we can take your names, maybe through Vinton, and submit that to our colleagues who are involved with the trial, and they can contact you when the next part of the trial begins.
The vaccines will be given at Rady Children's Hospital in a special area for research. And there will be plenty of time for the researchers to spend time with the parents, fully explaining any risks to the vaccine and potential benefits, and all of the visits that they will expect that the children will need to have if they sign up for the study.
Okay, very good. Do we have any other questions, folks? Again, you can put your questions in the chat or you can unmute yourself and ask.
If I may, I don't want to change the subject too much, but I would like to go into the different side effects or conditions that having coronavirus have been shown, and if this there's been any studies on memory impairment and different other conditions that are left behind by or have been shown to be more obvious a few months after you contract the virus. I wanted to know if there's any studies on that, to use that as a factor to encourage people to get vaccinated for those that have not contracted the virus yet.
It's a great question. The answer is yeah, they have. There's a couple of large studies that have looked at this. Fully a third of people who have been infected continue to have some sort of symptoms even 3 months later. Most of those people have fatigue. It's fatigue that doesn't seem to go away, and it can be really severe. Actually, my sister-in-law, who's a surgeon in the UK, got it while she was on her rounds, and she took 3 months before she could go back to work. There's another recent study that was published in The Lancet that looked at this specifically, and they looked at neurologic symptoms like you're asking. And they found that fully greater than a quarter of people had anxiety for months after. There are higher rates of depression and other neurologic symptoms as well, headaches, and even some severe disease. The risk of stroke and some of those other things have been shown to be higher after you have the infection. So it's a very good point that it's not just the 5 days or couple of weeks that can affect people. They can have long-lasting symptoms. And the term some people use is long hauler, which that's not necessarily a scientific term, but I think it does illustrate how long you can suffer from some of these side effects.
That was a great question. Thank you for asking. Does anyone else have a question? Oh, we have a question from, let's see. Oh, Denise says, is there an age requirement for kids to do the trials?
There are multiple phases in each trial that look at different age groups. And what we can do is, thank you, Dr. Bradley. So they'll start with the older kids first and then go down to the younger kids. If you are interested, submit your name and phone number, and you can just give the age of your child. That way we know when to reach out to you when they would be eligible. But the youngest children will be later on. And that's usually because you want to see the safety and efficacy data in older folks first before you test the younger children.
And folks, what I'll do is maybe tomorrow, later this week, I will do a follow-up email to all of you, since we have your email, since you signed up for to attend this town hall, and I can email you the information. So if you want your child to be in this study, you can reach out to them. We have a question from Alejandra. Does blood type have a significant impact on the rate and/or severity of infection to COVID?
That's a great question. There was a lot of concern that was true. These study done out of Iceland showed that people that had the infection seemed to have genetic type that correlated with blood type. When people studied that outside of that trial, they found that generally it wasn't the case. So your blood type really isn't a major contributor to the likelihood that you get infected or have severe disease. And there's a couple of studies that have looked at that now.
All right. Any other questions, folks? All right.
Well, Vinton, thanks so much for inviting us. Dr. Bradley and I both really enjoy sharing information, and this is energizing for us. If there's any feedback, they can send it back to us. I can try and make the next iteration better. Thanks so much for everyone's time.
Of course. Thank you both very, very much. We really appreciate your time and all this wonderful information. And folks, just again, I will do a follow-up email with you all. We'll provide information. We also have 2 town halls coming up, one in May and one in June. So that will be on the COVID variants. And the other one will be about what will school be looking like in the fall with our new world of COVID kind of thing. So thank you all for attending. And when I send the email, please feel free to email back with questions, with suggestions. We're happy to answer questions. So just keep an eye out for an email coming from us, okay? All right, thank you, Dr. Ramchandar and Dr. Bradley. We really appreciate your time. And thank you everybody for attending our SASEA Town Hall.
Thank you, everyone.
Thank you.